Hi, my name is Anthony Wong. I specialize in pediatric and open cerebrovascular neurosurgery in my practice, and today we're going to talk a little bit about AVMs in children. Today we're going to talk about brain AVMs, but we're going to focus on the aspects that pertain to pediatric patients. The vascular malformations that are commonly found in the brain and the spinal cord can be broken up into those with arteriovenous shunting and those without. We're going to focus purely on arteriovenous malformations, or AVMs, today. A joint review by the AANS, the CNS, and the American Academy of Neurology refined the operational definition of AVMs to specify that they include an abnormal complex of afferent arteries communicating with draining veins, distinct from other congenital vascular lesions. In practical terms, AVMs are defined by early venous drainage, the fact that their flow bypasses the capillary circulation, and the nidus can involve brain tissue. The nidus of AVMs can be characterized as compact, involving very little brain, or diffuse. AVMs can also be characterized in their flow as plexiform and fistulous. Fistulous components of AVMs typically involve a high flow shunt, whereas plexiform flow involves the typical tangled nidus. Essentially, all AVMs are disorders of development, but tend to be detected in two peaks in age, one in childhood and another at about the age of 40. Though they're pretty rare in that they're only detected in about 0.1% of the population, they do impact the young disproportionately, accounting for approximately 3% of stroke in youth. Intracranial hemorrhage is the most frequent presentation. About 50% of AVMs are detected in this way. The second most common presentation is seizure, detected in about a third of cases. Pretty rarely, AVMs present with ischemic symptoms or compressive symptoms. In a nice study by Brad Gross and Rose Du, approximately 4,000 patients were analyzed, and they found about approximately a 3% annual rate of hemorrhage. A couple of other studies, including the Aruba trial, subsequently have essentially corroborated this, that the annual rate of hemorrhage from brain AVMs is approximately 2 to 3%. Of course, one important risk factor for future hemorrhage is prior hemorrhage in AVMs, and accordingly, AVMs that present with rupture have shown a significantly higher rate or risk of rupture in the future. The natural history surrounding AVMs that are seen in patients with the genetic conditions associated with AVM development, including HHT and Wyburn-Mason, is a little bit unknown. There is some suggestion that these AVMs might actually be less liable to hemorrhage, but the numbers haven't really existed to arrive at solid conclusions. In the last decade or so, important discoveries about the genetic underpinnings of AVMs have identified somatic KRAS mutations underlying a large proportion of brain AVMs. This is in contrast with extracranial AVMs, where there's a little bit more diverse set of somatic mutations that are seen, including MAP2K1, KRAS, and BRAF. There has been some suggestion of an increased risk of hemorrhage based on demographic factors, including a higher risk for female gender, Hispanic ethnicity, and increasing age. However, it appears that the angioarchitectural characteristics of AVMs are probably the more reliable predictors of an increased risk for hemorrhage in the future. Most importantly, the history of a prior hemorrhage portends the highest risk of future hemorrhage. Singular or exclusive deep venous drainage appears to also confer a higher risk of hemorrhage. Perinatal arterial aneurysms, either within the nidus itself or along one of the feeding arteries. And finally, venous outlet stenoses or dilations may also portend a higher risk of hemorrhage. When counseling patients about management strategies available to them for their AVMs, all interventions have to be compared against observation and that approximately 2 to 3% annual risk of hemorrhage. Of course, lesions that demonstrate these high-risk features for hemorrhage or younger patients are much more likely to be recommended some form of intervention. For those patients where minimal neurologic deficits would result, surgery is easily the most effective form of intervention for AVMs, offering an immediate mitigation of hemorrhage risk and a minimal risk of recurrence after complete resection. For those lesions where a neurologic deficit is likely to be incurred with surgery, radiosurgery offers an excellent alternative. Obliteration rates as high as 80% have been reported in large series with smaller lesions, though the length of time it takes to effectively obliterate an AVM can last in the 2 to 4 year range. Though complication rates related to cerebral edema or necrosis are quite low, the larger the lesion, the more likely these are to occur. And so a couple of fractionation strategies can be employed to reduce that risk. Endovascular embolization of AVMs is rarely employed for primary treatment of AVMs, owing to a high rate of incomplete treatment, high rate of recurrence, and significant periprocedural stroke risk. They are, however, useful for micro AVMs as primary treatment, for management of fistulous components of AVMs as an adjunct to other forms of treatment, as a pre-surgical adjunct, and potentially as a radiosurgery adjunct. Though there has been some data to suggest that embolization prior to radiation treatment results in a lower rate of AVM obliteration. Obliteration rates with stereotactic radiosurgery depend a lot on size. For single treatment, the goal is to deliver 19 to 22 gray within a 12 gray constraint dose to normal brain surrounding. For larger AVMs, measuring 1.5 centimeters or more, it's common to employ one of two fractionation strategies, including volume staging, where the volume of the AVM is broken up into 8 to 10 cc fractions, or dose staging, where approximately 30 gray are delivered in 5 daily fractions. A higher likelihood of AVM recurrence after complete treatment is probably the thing that most distinguishes the care of AVMs in pediatric patients from those in adult patients. Even after complete resection or obliteration, there's approximately 15% risk of recurrence of AVMs in young patients, extending well out into their 20s. And this recurrence can occur as many as 5 or more years post-treatment. In my practice, I routinely follow patients out to the age of 26 with periodic imaging to surveil for recurrence. Probably the most important publication on this topic came from a joint effort between Utah and Ed Smith's group in Boston, and I'll show you some of the data that came from this publication. Among about 100 patients, a large majority of them either stayed the same or improved in terms of their presenting neurologic function. At the last follow-up, a significant proportion of patients initially presenting with a neurologic deficit experienced improvement of those deficits. In fact, 92% of patients out of this series had an MRS, a score of 0 to 2 in long-term follow-up. What's more, a large proportion of patients go on to complete education at a high level. And here you see that about 30% of these patients had completed a college degree, and only 5% had dropped out at some point due to poor grades. This is in comparison to the general population, where about 23% of people have a college degree as their highest level of education. So in summary, pediatric AVMs are not in their nature different than adult AVMs, but in the way that we counsel and select management strategies with our patients and their parents can be dramatically different than how we counsel adult patients. Spontaneous hemorrhage is still the most common and most impactful mode of presentation, and seizures are also a very frequent and important presentation for these. Surgery is the preferred intervention method where the lesion is amenable, but where it's not, stereotactic radiosurgery offers a very strong alternative. The approximately 15% rate of recurrence of even completely treated lesions implies that patients, even after treatment, do require follow-up. And when we do treat these lesions, we can expect, generally speaking, quite good outcomes as a whole. Thank you for joining me.